Welcome everyone, and thank you for joining the ERA seminar of today, which is organized by the DESCaRTES working group, the working group on kidney transplantation. The seminar belongs to the cancer and kidney transplantation series, and today will be about managing immunosuppression in patients, kidney transplant recipients who have been cured for cancer. That is, what is the best immunosuppression for those patients? My name is Umberto Maggiore. I'm a transplant nephrologist from the University of Parma, and I'm chairing the session. The speaker of today is Professor Rachel Hellemans. She's the head of the kidney transplant program at the Antwerp University Hospital in Belgium. She has a special interest in post-transplant cancer. In 2020, she participated in a SOTLJ working group, which was focused on management of immunosuppression after post-transplant cancer. Following this project, she became the first author of a review paper on this topic published in Transplantation International in 2021. After the talk, there will be a discussion which will be informal, so I encourage you to type the question in the chat. We have two panelists, namely Ilaria Gandolfini, a transplant nephrologist from the Transplant Outpatient Clinic in Parma, and Geir Mjøen from the Department of Transplant Medicine, Oslo, Norway. So now I'm very happy to give the floor to Professor Rachel Hellemans. Rachel.
Thank you. So, good afternoon, everyone. Thank you, Umberto, for introducing me. Thank you all for being here. So I will talk about the management of immune suppression in patients who have potentially cured post-transplant cancer. An overview of my talk, I will start with a general introduction, then discuss the possibility of reducing the overall immune suppression, switching from a calcineurin inhibitor to an mtor inhibitor. How about switching to an mtor inhibitor plus a low-dose CNIs? Then I will briefly touch upon the use of immune checkpoint inhibitors after transplantation and end with a few take-home messages. So, unfortunately, as we all know, our kidney transplant patients are at increased risk of developing cancer after transplantation. And in some cancer types, this is clearly virally driven, like, for example, Kaposi sarcoma or lymphoma. While in other cancers, there is no clear link with oncogenic viruses, but the increased risk of these cancers is thought to be caused by direct drug oncogenicity and or the reduced immune surveillance, so reduced control of cancer cells. And there's more bad news for our patients. Not only do they have a higher risk of getting cancer, but when they get cancer, these cancers tend to behave more aggressively. And this is nicely shown in this study, the table I show here, which is about a very large American registry study, which compared the cancer outcomes of transplant patients versus non-transplant patients, patients from the general population with cancer. And in this table here, we see the outcomes or the cancer-specific mortality for patients with a local stage cancer, so receiving curative treatment, so the cancers with the best prognosis. But as you can see here, for many of the common cancer types like colorectal cancer, lung, melanoma, breast, etc., we see that transplant patients have about a 2 to 3 times higher risk of dying from, in this case, a recurrence of their cancer, which suggests that even local stage cancers, cancers with a seemingly good prognosis, tend to be prognostically less good in transplant patients because of an earlier step to micrometastasis, for example, probably. So this is probably, at least in part, again, due to this reduced immune control of the cancer cells. So in this respect, it seems a logical step when your transplant patient develops cancer to try and reduce the overall immune suppressive load and or to switch to another regimen, maybe, while of course balancing this against the risk of rejection or other adverse events. Now, is there any evidence to guide us in this very difficult decision on what to do with our patients? Well, how about the evidence? For non-melanoma skin cancers, we do have 3 RCTs, which show that switching patients with non-melanoma skin cancer from a CNI to an mTOR inhibitor can, at least to some extent, reduce or delay subsequent skin cancers. Although there's an important note to make here. If you do the switch, you should do it in a quite early phase of the disease process, so preferably after a first kidney cancer, because the benefit of switching seems to diminish with more previous cancers. Okay, now for other cancers, unfortunately, there are no RCTs. There is almost no evidence to help us out here. So existing guidelines and consensus documents, they are based on indirect evidence and expert opinion. And if you look at these guidelines and documents, they generally state something like, first assess the cancer prognosis and the risk of rejection, and then consider decreasing the overall immune suppression. And some consensus documents also suggest to consider switching to an mTOR inhibitor, either with or without low-dose CNI. Okay, so if we first have a look at the decrease of overall immune suppression, which sounds logical to me, which drug to decrease then? So usually our patients are on something like MMF, CNIs, and steroids in the majority. Well, MMF is probably not the main driver of the cancer risk. If you look at these registry data, large registry data, you see that regimens with or without MMF, they seem to lead to a similar cancer risk. And the same goes for the steroids. This is a meta-analysis of RCTs showing no clear difference in malignancy risk with or without maintenance steroids. It's probably the calcineurin inhibitors that are the main culprits here, because there is quite compelling evidence that the CNIs are carcinogenic. For example, by inducing TGF-beta-1, by inhibiting DNA repair and apoptosis, and also in clinical studies, both in transplantation as well as in other fields, it seems that higher doses of cyclosporine and tacrolimus lead to a higher risk of cancer. So from an oncological point of view, it would be most interesting to get rid of the calcineurin inhibitors. But unfortunately, that is also the most risky thing to do in terms of rejection. But how about not just stopping the CNIs and continuing on something like MMF and steroids, how about replacing the CNIs with an mTOR inhibitor? We know that the mTOR pathway is a key regulator of the cell cycle and is often hyperactivated in cancer. And we know that mTOR inhibitors can, at least in some settings, slow the proliferation of cancer cells and tumor angiogenesis. And this has also led to the use of these drugs as a treatment for certain advanced cancers. So it's an approved therapy for certain advanced breast cancers, for progressive neuroendocrine tumors, and for advanced renal cell carcinoma. Now, given their oncological potential, there is understandably much interest in finding out if these mTOR inhibitors could also have a kind of protective effect against cancer in the transplant patients. Now, how about the evidence on that? Well, if we look at regimens with mTOR inhibitors versus CNI, there's quite consistent evidence that this reduces the risk of developing non-melanoma skin cancer. This was both shown in large registry data. It was confirmed in meta-analysis of RCTs. And as mentioned earlier, we have these 3 RCTs on the secondary prevention of non-melanoma skin cancer when patients are switched from CNIs to mTOR inhibitors. But that's the skin cancer. The benefit of the mTOR inhibitors is less clear for other cancers. Let me first show you some large registry data. These are data from the collaborative transplant study. Now, if you look at figure B, you see what we just talked about. Patients on an mTOR inhibitor have a lower risk of developing non-melanoma skin cancer after transplantation than patients who are not on an mTOR inhibitor. But if we look at other cancers, we see no difference. And the same was found in a United States registry study that found overall no significant reduction in cancers other than non-melanoma skin cancer with sirolimus. In fact, they also looked at different cancer types. They found an increased risk of prostate cancer with sirolimus, while there was a trend towards a similar or lower risk for some other cancers with sirolimus. Now, okay, these are just registry studies. We know that they can have all kinds of limitations, biases, but also meta-analysis on randomized controlled trials, which we see as the most solid evidence we can have. They come to the same conclusion, as you can see here. The risk of other cancers, so non-melanoma skin cancer, there was no significant difference between regimens with sirolimus versus CNI-based regimens. And also in a second meta-analysis published a year later, they came to the same conclusion. And interestingly, in this study, again, they looked at different cancer types, and they actually found an increased risk of prostate cancer with sirolimus, while there was, for example, a decreased risk of kidney cancer with sirolimus. Okay. Now, why is there so little clear evidence on the benefit of the mTOR inhibitors in cancer prevention, excluding the non-melanoma skin cancer for now? Well, first of all, the mTOR inhibitors in oncology, they have only shown a benefit in a small selection of cancers. For example, there were failed trials in lung, gastric, colorectal, and prostate cancer. Also, very important to know that these mTOR inhibitors primarily work as a cytostatic. They're not really cytotoxic. So they are used in advanced cancers, and they usually rather lead to disease stabilization and not really tumor shrinkage. So maybe it would be a bit too optimistic to hope that these mTOR inhibitors could really prevent the development of cancer. But at least hypothetically, you could argue maybe they could help to slow down the progression of a cancer once it develops. But then again, maybe not, because the dose that is used in cancer is much higher than what we use in transplantation. So in oncology, they use a fixed dose of 5 to 10 milligrams of everolimus per day. This often yields trough levels way above 10 nanograms per ml. So a dose that we rarely use and is often poorly tolerated. Well, anyway, even if the mTOR inhibitors may not have a real cancer fighting, a real anti-cancer effect, you could still say, well, at least they are probably better than the clearly oncogenic CNIs. And I guess that makes sense. But what is holding many of us back to using these regimens, CNI-free mTOR-based regimens, is, for example, the fact that these regimens are not always well tolerated. There are frequent adverse events. Many RCTs show that about 20% of patients have to stop their mTOR inhibitor because of side effects. Also, many studies showed an increase of rejection when you switch patients from a CNI to an mTOR inhibitor. And finally, there have been reports on a higher mortality with mTOR inhibitors. So these are the reasons why such regimens are nowadays not so much used. But in the last years, there has been more interest in using mTOR inhibitors combined with a low dose of CNI, like in the Transform study. So would that be a good option for our patients with cancer? Well, the good news about such regimens is that they are better tolerated and have a lower rejection risk. But on the other side, from an oncological perspective, in this case, you usually use even lower doses of mTOR inhibitors while you keep a low dose of these oncogenic CNIs. So we don't have enough long-term data yet to really know what the effect of this regimen is on cancer risk. So a first meta-analysis suggests that indeed using such regimen may reduce the risk of cancer, but we need to have more data to give you solid advice. Furthermore, there are little data on the safety and tolerability of switching to an mTOR inhibitor with low-dose CNI yet. And finally, as is also true for the other strategies, it's really unknown if they can improve the prognosis once a post-transplant cancer occurs. I would like to end with some words about the immune checkpoint inhibitors. I will keep it short because in a recent e-seminar from September last year, Umberto Maggiore, he already discussed this topic in nephrology very extensively. So I will only focus on the aspect of maintenance immune suppression. So these immune checkpoint inhibitors, they can work via two possible mechanisms, but the effect is that they unleash the T cell immune response against tumor antigens. And by doing so, these drugs have really given a big breakthrough for many difficult to treat cancers. But not surprisingly, transplant patients were excluded from the studies with these drugs, because if you want to break the tolerance against cancer cells, you might as well risk breaking the tolerance against your transplant, of course. But nevertheless, with time, more and more reports became available about the use of these drugs in transplant patients. And by now, several case series have been published. Now, it's very difficult to draw firm conclusion from these case series, which include a real mix-up of patient types, cancer types, immunosuppressive regimens. So really very difficult to conclude something from them. But what we could say is that generally the risk of acute rejection after starting these immune checkpoint inhibitors in transplant patients is very high. It is about 40%. And it happens early, typically in the 2 to 4 weeks after initiation in the majority of patients. It's mostly very severe, either severe T cell or combined B and T cell, leading to graft loss in about 70% of the patients. It seems that the lower the maintenance immune suppression, and especially when patients are on monotherapy, the higher the risk of getting rejection. Again, here some authors suggest that there could be a protective effect of the mTOR inhibitors, but this is for now only based on very low quality evidence, so we cannot draw any firm conclusion about this yet. Now, what was also seen in many of these patients described in this series is that often the immune suppressive regimen was reduced at the start or just before the start of these immune checkpoint inhibitors. So you might ask yourself if this high risk of rejection could maybe be in part due to this concomitant lowering of immune suppression. And interestingly, this or last year, a first, albeit small, prospective multi-center study was published, in which 17 kidney transplantation patients were allocated to nivolumab treatment, but it was important that there was no change in immune suppression around that time. And this resulted in 41 patients who remained on triple therapy, only fewer on mTOR inhibitors. Now, interestingly, they showed a tumor response in 53%, which is quite comparable to what is expected as a response in the general population. But the risk of rejection was remarkably low. Only 2 out of 17 developed rejection. So although it's very early to tell, the authors suggest that if you maintain your immune suppression at the start of the treatment, you may get a similar efficacy, but maybe less rejection. So it's too early to make firm conclusions here again, but it's interesting. And fortunately, other prospective studies are now ongoing to try and find out what we should do with these treatments in the future. And so with this, I would like to close with some key messages. Remember that we have very, very little direct evidence to guide immune suppressive management in post-transplant cancer. You could consider an overall reduction of immune suppression, but of course balanced to the risk of rejection. The use of mTOR inhibitors, the rationale for this is mainly based on indirect evidence. mTOR inhibitors, or regimens with mTOR inhibitors, have shown to reduce the risk of non-melanoma skin cancer after transplantation, but it is unsure if they also reduce the risk of other cancers, or if they can improve prognosis in case of cancer. And we have to keep in mind that switching to a CNI-free mTOR-based regimen could increase the risk of rejection or other adverse events. About immune checkpoint inhibitors, remember that there is a very high risk of rejection reported, and some preliminary data suggest that you could get better outcomes if you maintain the immune suppression. Thank you for your attention.
Thank you, Rachel, for this fantastic presentation, which was very clear. You kept it short and simple. I would like in this discussion that you provide some practical advice for the transplant nephrologists that can be used in the daily practice. So, in your personal experience, how do you manage immunosuppression after cancer, at your center? For instance, also, what level of, if you use mTOR inhibitors, what blood levels do you keep in your patients?
Okay. Yes, I must say that we don't have a fixed approach to patients who develop cancer. It's very individualized according to the treatment the patient is on and the risk of rejection, the kidney function, and the prognosis, of course. But I could give you two scenarios. And like, for example, in a patient with a cancer with a good prognosis, treated with curative intent, say someone who has a small renal cell carcinoma of his native kidney. If this patient has good transplant function, no proteinuria, so it's someone that you expect could tolerate mTOR inhibitors, I would be keen to try and avoid continuing on the CNIs because they are oncogenic, we know that. I'm not sure that it could prevent metastases that would be already there. I don't think it would be able to stop it, but maybe it could prevent a second cancer from developing or something. So in that case, I do consider switching them to an MMF mTOR-based regimen in case I would target trough levels of everolimus of 5 to 8 nanograms per ml and give a good dose of MMF together with that, like for example, 1,500 milligrams per day. And most of the time also a low dose of prednisolone. So that would be one strategy for a good patient in which I want to prevent other cancers. But if this patient has a bad prognosis, either because of his cancer or because of comorbidities and age, etc., I would try to avoid complex changes to the regimens. I would focus on maintaining a good graft function with a minimum of immune suppression. So then we often use a regimen like tacrolimus with a trough level of 5 and prednisolone 5 milligrams.
Okay, thank you. Ilaria, do you share this view? And if you had to say, list the patient's characteristics that that affect your decision, for instance, to switch to mTOR inhibitors? What would you say about it? And then if another question I would like to ask you, the mTOR inhibitors may be poorly tolerated by some patients. If you switch a patient to mTOR inhibitors, what are the adverse effects that, in your view, justify their withdrawal, complete withdrawal, and resuming to the previous maintenance immunosuppression treatment?
So in our experience, we don't have guidelines, of course, but so we normally try to reduce the immune suppression burden in case of a normal immunological risk patients. And of course, we have to balance between the risk of recurrence or micrometastasis increase and the risk of rejection. So it depends. So for example, we are switching to mTOR plus steroid from a triple therapy only in the first non-melanoma skin cancer or in Kaposi sarcoma. In all the others, normally we are trying to lower the immune suppression in different ways according to the risk of patients. From CNI to mTOR inhibitors, we have to consider the patient characteristics. So starting from the immunological risk, if the patient has had rejection, DSA, hyperimmune patients, so they are at more risk of rejection in case of a CNI mTOR-based regimen. Could be in some cases a hazard to do it, or like for example, some patient that has already have low EGFR or proteinuria can have a very bad side effects, and also in some cases with a very moderate to severe edema from the baseline, they are not normally tolerate the side effects of mTOR that are, I mean, for the main side effects that can cause the withdrawal of these drugs are normally proteinuria. And in fact, if we already have some proteinuria, normally it increases a lot, despite the withdrawal of calcium channel blockers and the starting of RAS blockade. They can have edema, and in some patients, like 10% pneumonia, even a lot anytime after the mTOR initiation. Normally, hypertension, dyslipidemia can be controlled, and they are normally a side effect that can cause the withdrawal of these drugs. But I mean, these are very good drugs, ideally, but the side effects are normally are often limiting their use.
So if they develop edema, for instance, peripheral edema, do you try to convince the patient to keep on mTOR inhibitors, or you just
before switching to mTOR inhibitor, we are normally try to introduce, if tolerated, the RAS blockade that normally can diminish the edema. And some patients cannot really tolerate this drug with a very severe edema. And in this case, I mean, since they are treated from the cancer, they do not have the cancer at that moment, we can also have to give a medication that a patient can tolerate, and to avoid medication non-adherence also.
Okay, so we are talking about the best lifetime maintenance anti-rejection regimens. Do you take also into account the age of the recipients? I mean, younger age implies longer life expectancy and therefore maybe even more risk of rejection. Do you take that into account in your choice?
It depends on the cancer because younger age, it also can mean increased risk of rejection, not only. So yeah, we are normally actually working very close with the oncologist also to evaluate the risk of recurrence also in our patients. So I think that we should do that.
Geir, what about you? What is your take on this matter, and especially, do you make different decisions concerning mTOR inhibitors according to the fact whether the patients have skin or non-skin cancer? And another issue that we didn't touch. What about the patients who have been cured for post-transplant lymphoproliferative diseases? What do you do with their lifetime maintenance and rejection treatment?
If I start with the first one, skin cancer versus other cancers. So for non-skin cancer, I know that in Rachel's presentation, there was not much evidence for non-skin cancer, and that is also my perception of this. So we say that when we consider mTOR inhibitors in such patients, still, because still we do that sometimes after cancer, then we would take into account several factors. Maybe not because it's such precision medicine, but most of all because we still do not know. And when you look at the literature and the studies and you start to divide up the groups, these endpoints with non-skin cancer, you see that when you start dividing them up, it's actually very few of each type of cancer. So it's very hard to interpret these studies also as negative studies in that sense, because it's a lack of power. So most of all, there is a lack of evidence for these patients. So still we individualize, and for non-skin cancer, sometimes we would discuss mTOR inhibitors. I think it would vary from patient to patient and doctor to doctor. And most of all, we have no clear routine or rule for discussing mTOR inhibitors with such patients, but we make some individual considerations. Regarding the skin cancers, when we have transplanted patients in our outpatient clinic, usually we have the same patient year after year. And if one skin cancer develops, that would be perhaps a good time point of discussing a switch to mTOR inhibitor. Either replacing the CNI or with if there is some doubts about tolerability, maybe going for the transform protocol with reduced CNI and replacing the MMF with mTOR. And it's important to do that early, because the studies that found effect on the skin cancers, non-melanoma skin cancers, also did not find any effect when there were several cancers or these patients had a longer time with skin cancers.
Okay, thank you. Rachel, you mentioned that steroids has a neutral effect on cancer incidence. However, also the overall immunosuppression may matter. Do you usually reduce the dose of steroids in those patients for their lifetime maintenance therapy?
In our center, we keep the majority of our patients on steroids. And personally, I have the feeling that stopping the steroids alone would not really affect the risk of cancer recurrence. It's my feeling, but of course I cannot prove it, so it would not be an option that I would often use.
Okay, and you didn't address the issue of belatacept. Do you think that belatacept might be an option in these patients?
Yes, an interesting thing. The problem is I have no experience with it because in Belgium it's not reimbursed. And for now, there is not a lot of experience or a lot of reports on cancer on belatacept treated patients. So for now, we cannot be sure if that would really benefit. You know that with the benefit study, this raised some concerns even about the risk of PTLD. Still, the numbers of PTLD in this study were very small, so it was not clear. Later, a meta-analysis of 5 randomized trials comparing belatacept versus CNI also looked at this, could not find a clearly increased risk of PTLD with belatacept, but on the other hand, it's not possible to rule it out either because of the low numbers. So I think there is still this cautiousness about a possible risk of PTLD with belatacept, but for other cancers, there's no clear sign, but we don't have any solid data on that either.
And would you recommend mTOR inhibitors in patients with a history of PTLD?
Well, some some reports suggest that the mTOR inhibitors could have a kind of protective effect against PTLD. It's mostly EBV driven, and we know that mTOR inhibitors could have antiviral effects. But for now, in clinical studies, studies, it's mostly retrospective reports. There is no proof that using mTOR inhibitors would be a better option for the PTLD patients. There's no proof yet. And in fact, about this antiviral effect, that is of course very intriguing. For now, we only have clinical proof that regimens with mTOR inhibitors can reduce the risk of CMV and polyomavirus. That's proven. But although in vitro and in experimental models, mTOR inhibitors seem to also have a direct and indirect effect against other viruses like EBV or others, so oncogenic viruses. But still, in the clinical studies, it's not clear, and of course it's very complex. Although the mTOR inhibitors could have some kind of antiviral effect, there's also the immune suppressive effect that could counterbalance that, and also the patients are on other immune suppression. So the netto effect on viral replication is very hard to predict. And I repeat that for now, there is no real evidence that it can really block the proliferation of oncogenic viruses and cancers driven by viruses.
Okay. Ilaria, when you make a change in the maintenance immunosuppressive regimen, say switching from mycophenolate to mTOR inhibitors, or from calcineurin inhibitors to mTOR inhibitors, or reducing the level of calcineurin inhibitors, whatever. What is the recommendation about how often to check renal function, proteinuria, donor-specific antibodies? How do you do it in practice?
So there are no shared recommendation. I think that this is a very important point because nobody knows how to do it. So everybody has his own recipe. Our recipe is to check the kidney function and the proteinuria at least every 2 weeks at the beginning for the first 2 months, and then try to keep the patient tight. So doing also DSA we are doing at month 1, 3, 6, and then yearly like the others. We have to check for the blood pressure, dyslipidemia. We have to check for the proteinuria. So these are not patients that you can just give a follow-up like the others. When you decide to change immunosuppression, in any case, you have to keep them at tight control. So we have also to consider that if a patient is not able to come to the visit or to do to perform more often blood tests, I mean, we have to consider all these issues.
When you switch it from calcineurin inhibitors to mTOR inhibitors or another kind of switch, what is the time schedule of the, say, calcineurin inhibitors withdrawal and so the timing of the timing when you check blood levels?
So to get to the steady state every 2 weeks at the beginning, and then we can increase the period. And so for the
Everodimus, you mean?
For Everodimus, yes. And for the so if we are just reducing the immune suppression, we are using this schedule. And in case of switching to mTOR, we are also checking more often the cholesterol and all proteinuria, all this stuff.
Geir, for those patients, would you, for stratifying their baseline immunological risk, would you recommend to perform a biopsy or maybe to use some biomarker?
I am not aware of any specific biomarker that we use in the clinic now. Maybe sometime in the future or near future, something will become available to help us. A biopsy could sometimes be useful in some patients. At least we could discuss it. If there is a patient with this high immunological risk with several risk factors, maybe it is a short time after the transplant was performed. Maybe we know there are DSAs. Maybe there is a history of not that good compliance or other things with the graft. Then we would still have a high level of uncertainty also after the biopsy. It would not turn things into black and white, but it could be good to have a baseline biopsy at least to guide us also when there is a change in graft function later and we want to have a biopsy later on. So I think it's for these specific types of patients, I think it's something that we should discuss, yes.
And if you perform a biopsy and you find a subclinical rejection, or maybe it is you don't find it, but then the patients eventually develop a rejection, would you treat the patients as anybody else, or differently?
First, for the acute rejection treatment,
yes,
we would do, for most types of rejections, it is common to start with the steroids, and I think it's quite uncontroversial, and we would do the steroids as usual. And these other types of rejection treatments, the one that would be the most difficult and the most important to discuss with your colleagues would be if it is a rejection that normally would require use of thymoglobulin short time after cancer, maybe something virus driven, or maybe something of a lymphoma, then that would be a very difficult decision, and it is, I think, very few doctors would have a clear answer. But then when you look at the rejection, then some things there would perhaps guide you also. If it's a very severe rejection, that would pull you in the direction of heavier rejection therapy. And also then, if this is a patient who you have a very clear indication for mTOR inhibitor, and you have provided the patient with information before you started, also including the risk for rejection, then you would have to discuss with your colleagues and also with the patient again, and maybe this would be, maybe you have no other option than to change the baseline immunosuppression. Maybe you have to, if you are on MMF and mTOR inhibitors, maybe you have to change it to low dose mTOR inhibitor and reintroduce the CNI. You're probably on a low dose steroid protocol anyway, so that there's not much to do there, but these things are, it's a very difficult landscape, and it's individualized, and I think it's also important to have plenary discussions, and also discussions perhaps involving the patient's, the oncologist that is treating the patient, if the patient still has a relationship to that doctor. Yes.
One last question for Rachel. If the patient is already on mTOR inhibitors and develop a cancer recurrence, what would you do? Would you further change immunosuppressive treatment, or just give up about changes?
Yeah, it's a recurrence from the same cancer. So really
the same cancer.
Yeah, with a bad prognosis, and I guess in many situations not curable, then I would focus on not risking rejection, because I think it's more important for most patients, for the time they have, that they can keep their kidney function, not go back on dialysis for the last months in their lives. Maybe, of course, this is something to discuss with the patients. You could, he should be involved in the decision, but we don't have clear evidence to change the drugs, and we risk rejection. So I think in most cases, I wouldn't do another switch.
Okay. So now we have 5 minutes to go. Maybe I could recap the key messages from this webinar. So first, for kidney transplant recipients who receive the treatment for cancer with curative intent, there is no evidence on what is the best maintenance therapy. However, as Rachel mentioned, there are some indirect evidence that can be used for clinical practice. First, there is no magic bullet, of course, concerning the anti-rejection treatment, because some regimens may reduce the risk of recurrence, but also increase the risk of rejection and side effects. So the choice should be made by sharing the decision with the patients and doing some personalized decision, taking into account the immunological risk of the patients on one side and the other, the risk of recurrence. Switching to mTOR inhibitors may be, of course, regarded as a good option and must be considered. However, it is not a mandatory option. Reducing overall immunosuppression, especially calcineurin inhibitors, is a viable option as well. When switching to mTOR inhibitors, we have two options: switching from mycophenolate azathioprine to mTOR inhibitors, or switching from or withdrawing calcineurin inhibitors and starting mTOR inhibitors. And these two regimens have pros and cons concerning the tolerability and the anti-cancer effect. So I would close this session and thank Rachel and the panelists for the nice discussion and also thank the attendees for connecting. I hope that this webinar has been useful for everyone.